Okay. Good afternoon, everyone. It's a pleasure to welcome you to this focus session on anterior triangle of the neck, a region that's deceptively simple in shape, yet profoundly important in clinical practice. As surgeons, radiotherapists, and anatomists, we often return to this triangle not just for its textbook boundaries, but for the vital structures it protects and the surgical access it offers. Today, we'll walk through its anatomy, subdivisions, and clinical relevance with a clear eye on how this knowledge translates to safe procedures and confident decision making. Let's begin by defining its boundaries and understanding why these triangles remain a cornerstone of head and neck anatomy. Now let's begin with a foundational concept in cervical anatomy, the triangles of the neck. These anatomical zones aren't just theoretical divisions. They serve as practical guides for surgical access, trauma evaluation, and diagnostic precision. The neck is divided into two major triangles by the sternocleidomastoid muscle. So remember this, it's divided by the sternocleidomastoid muscle. The anterior triangle, which lies in front of it, and the posterior triangle, which lies behind. Each of these contains vital structures and is further subdivided into smaller triangles that we'll explore in detail. Understanding these regions help us navigate everything from lymph node biopsies to vascular procedures with confidence and clarity. So, let's take a closer look at how these triangles are defined and why they matter. Now that we have seen how the sternocleidomastoid divides the neck into two triangles, anterior and posterior triangles, let's focus on the boundaries of the anterior triangle itself. This triangle is shaped like an inverted pyramid, and its borders are defined by three key anatomical landmarks. Anteriorly, we have the median plane of the neck running straight down the midline from the chin to sternum. Posteriorly, it's bounded by the anterior border of the sternocleidomastoid muscle, the same muscle that helped us divide the neck earlier. So this is sternocleidomastoid muscle. So, and superiorly, the triangle is capped by the base of mandible, forming its upper limit. So these boundaries are not just academic, they guide our approach in procedures like central line insertions, thyroid surgery, and lymph node mapping. So in the next slide, we'll look into how this triangle is further subdivided into smaller, clinically distinct zones. Having defined the boundaries of the anterior triangle, now let's look at how this triangle, this region is further organized. The anterior triangle is subdivided into four smaller triangles, each with distinct anatomical contents and clinical significance. These subdivisions are formed by two key muscles, the digastric muscle and the superior belly of the omohyoid, which act as internal borders within the larger triangle. The four subdivisions are the submental triangle, the submandibular triangle, the carotid triangle, and the muscular triangle. In next few slides, we'll explore each of these in detail, looking at their boundaries, contents, and surgical relevance. Let's now explore the submental triangle, a compact yet clinically significant space beneath the chin. Though often overlooked, it plays a key role in lymphatic drainage and surgical access. So, what are the boundaries of this submental triangle? Apex formed by the symphysis menti, where the two halves of the mandible fuse, and base made by the hyoid bone. So this hyoid bone is formed in the inferior border of the submental triangle, and sides by the anterior bellies of the digastric muscles left and right. So we get our left digastric muscle, anterior belly of left digastric muscle, and the anterior belly of right digastric muscle. Flow is made by the mylohyoid muscle, also known as the diaphragma oris, forming a muscular sling beneath the oral cavity. Now that we have outlined the boundaries of the submental triangle, let's examine its contents, which are crucial for both clinical examination and surgical planning. So, what are the key structures within the submental triangle? So, first thing we encounter is submental lymph node. This lies just beneath the chin and drain the anterior floor of mouth, tip of the tongue, and lower lip. They are often the first to enlarge in oral infections or anterior tongue malignancies. Now we move on to the submental veins. These small veins converge to form the anterior jugular vein, which descends along the midline and connects via jugular arch with just above the suprasternal notch. So then external jugular vein, though more lateral, it receives tributaries from the submental region and drains into the subclavian vein, a major vessel returning blood to the heart. Next is jugular arch, a transverse venous connection between anterior jugular veins, visible in imaging and relevant in tracheostomy and central line placement. This is jugular arch. You can see it connecting both IGV. Then the suprasternal notch, a palpable landmark at the base of the neck, guiding access to deeper structure. So palpation of submental node is routine in head and neck examination. This is, you have to remember, this is important to palpate submental node. Now examine the submandibular triangle, also known as the digastric triangle, a key anatomical zone beneath the mandible. This area is rich in surgical and diagnostic importance. So, boundaries of this submandibular or digastric triangle from the above is the base of mandible. So, superior boundary is made by the base of mandible, and anterior belly of the digastric muscle, and posterior belly of the digastric and stylohyoid muscle. So posterior belly of digastric and stylohyoid muscles. So what about the flow? Flow is made by mylohyoid muscle anteriorly and hyoglossus muscles posteriorly. Okay, now that we have defined the boundaries of the submandibular triangle, let's explore its contents, which include a dense cluster of vascular, neural, glandular, and lymphatic structures, each with surgical and diagnostic significance. So, what are the major structures within this triangle? Submandibular salivary gland, the dominant occupant, nestled between the mylohyoid and hyoglossus muscle. Then submandibular lymph nodes, so they drain the flow of mouth, tongue, and lower face. Next, we see the facial artery and vein. These vessels traverse the triangle, often encountered during gland excision. So these veins often encountered during the submandibular gland excision. Next, hypoglossal nerve causes deep to the mylohyoid, okay, and it's supplied to the tongue muscle. So it's for the innervation to the tongue muscle. So and it causes deep to the mylohyoid muscle. Submental artery, a branch of the facial artery supplying the anterior flow of the mouth. So submental artery, it's a branch of facial artery. Then mylohyoid nerve and mylohyoid vessels, these branches of the mylohyoid nerve are branches of the inferior alveolar nerve, so innervating the mylohyoid and anterior digastric muscles, and also a part of the parotid glands occasionally extend into the posterior triangle. That means parotid glands lies in the submandibular triangle, but occasionally part can extend into the posterior triangle. So next, external carotid artery, which supplies the facial artery and other branches. So carotid sheath and its contents includes, what are the contents of carotid sheath? Includes the internal jugular vein, common carotid artery, and vagus nerve. So especially in clinical perspective, when we are doing submandibular gland excision, we require careful dissection to avoid injury to facial artery and hypoglossal nerve. Also, as mentioned in previous slide, so when head and neck examination, lymph node palpation is essential in head and neck examination. So you should know where these small submental lymph nodes are located. And from the radiotherapy planning perspective, you must account for the proximity of vascular and neural structures, especially when you are planning anterior neck fields. Now we turn our attention to a vital anatomical landmark, the carotid triangle. Though small in size, its significance in clinical practice is immense. But before we explore its contents, we must first understand its boundaries, for they are the roadmap to safe and effective navigation. Superiorly, we find the posterior belly of digastric muscle, a slender muscle that arcs backward from the mandible, helping define the upper edge. Inferiorly, the superior belly of the omohyoid muscle marks the lower border, sloping upward from the shoulder girdle towards the hyoid bone. Posteriorly, the sternocleidomastoid muscle stands tall and firm, forming the lateral wall and guarding the triangle's contents. These boundaries are not arbitrary, they are anatomical signposts. They help us locate the carotid sheath, which houses the common carotid artery, internal jugular vein, and vagus nerve. They guide us during central line placement, carotid endarterectomy, and even in trauma resuscitation. Understanding these borders is not just academic, it is practical, surgical, and life saving. So let us respect the geometry of the neck, let us teach it with clarity, learn with precision, and apply it with care. Let's now zoom into the carotid sheath, a facial compartment within the carotid triangle that houses some of the neck's most vital structures. Understanding its internal layout is essential for safe surgical navigation and radiotherapy planning. So, what is the carotid sheath? It's a condensation of deep cervical fascia that envelopes three key structures, each with distinct position. Common and internal carotid arteries, internal jugular vein, vagus nerve. So common and internal carotid arteries located medially closest to the midline. So internal jugular vein positioned laterally, draining blood from the brain and face. Vagus nerve nestled between and slightly posterior to the artery and vein. So what are the clinical relevance of this carotid sheath? Central venous catheterization target the IJV. Knowing its lateral position is a key. So you should be know the lateral position when you are doing the catheterization of IJV. So endarterectomy, carotid endarterectomy requires careful dissection around the medial artery. So in the carotid sheath, which structures lies most medially? Yeah. What is the structure lies most medially? It's common and internal carotid arteries. Yeah. Now let's dissect its arterial contents, each with distinct anatomical landmarks and branches crucial for diagnostic and interventions. So we'll see what are these arteries located in the carotid triangle. So termination of the common carotid occurs at the carotid triangle at the level of the disc between C3 and C4 aligned with the upper border of the thyroid cartilage. So here it bifurcates into proximal part of the external carotid and proximal part of the internal carotid. So the proximal part of the external carotid the anterior branch supplying the face and neck, and the proximal part of the internal carotid, the posterior branch. It's the posterior branch, and it's ascending intracranially to supply the brain. So there are five branches of the external carotid. So at the bifurcation level, these major arteries provide vascular supply to what? Thyroid, pharynx, tongue, face, and occiput. So thyroid get the blood supply via superior thyroid artery, pharynx get the supply via the ascending pharyngeal artery, while tongue receive the supply from the lingual artery, face via the facial artery, and finally occiput via the occipital artery. So now let's see the venous anatomy within the carotid triangle. So this venous structures are essential for drainage and access, venous access and staging in head and neck procedures. So this is very important structure. What are the venous structures we encounter within the carotid triangle? Internal jugular vein, the dominant vein in the triangle, running lateral to the carotid arteries within the carotid sheath. So it drains blood from the brain, face, and the neck. So next you will encounter tributaries of the IJV. These veins converge into IJV and reflect drainage from multiple regions such as common facial vein formed by the union of facial and anterior retromandibular veins. Lingual vein drains the tongue, and superior thyroid vein drains the upper thyroid lobe, while middle thyroid vein, often variable, draining the mid-thyroid region. Pharyngeal veins drain the pharynx and adjacent structures. So these tributaries drain into the IJV, the dominant vein in the carotid triangle. Okay, let's now see the neural anatomy within the carotid triangle. Beginning with two key nerves intimately associated with the carotid sheath itself. These two nerves associated with the carotid sheath itself. These nerves are embedded within the facial walls and play critical role in motor control and autonomic regulations. So what are these nerves? Yeah. Ansa cervicalis formed by anterior rami of C1, C2 and C3. This motor loop is embedded in the anterior wall of the sheath. It innervates most of the infrahyoid muscles, aiding in swallowing and speech. Then sympathetic trunk located in the posterior wall of the sheath. This autonomic chain regulates vasomotor tone, pupil dilatation, and sweat gland activity in the head and neck. Let's now explore the three cranial nerves that traverse the space between internal jugular vein and the internal carotid artery. These nerves are critical for motor, sensory, and autonomic functions in the head and neck. What are the three nerves between IJV and ICA? Vagus nerve descends vertically within the carotid sheath, position between IJV and the common carotid artery. It provides parasympathetic innervation to thoracic and abdominal organs and motor supply to the pharynx and larynx. Then spinal accessory cranial nerve 11 crosses the IJV and passes deep to the sternocleidomastoid muscle, eventually reaching the posterior triangle to innervate the trapezius. hypoglossal nerve running of 12 crosses both the internal and external carotid arteries, then dives deep to the posterior belly of digastric to enter the digastric triangle, supplying the motor innervation to the tongue. To complete our survey of the carotid triangle, let's highlight the deep cervical lymph node. Small but clinically powerful structures embedded within the facial structure of the neck. These nodes are embedded in the anterior wall of the carotid sheath, running alongside the internal jugular vein. They form part of the deep cervical chain, which extends from the base of the skull to the clavicle. Muscular triangle, its boundaries and orientation. Let's now examine the muscular triangle, the most medial and superficial of the anterior neck subdivisions. Though less vascular than the carotid triangle, it's rich in muscular and visceral anatomy, especially relevant to the thyroid surgery and tracheostomy. What are its boundaries? Anteriorly, midline of the neck, from the chin to the sternum. Superiorly, superior belly of the omohyoid muscle. Inferiorly, anterior border of the sternocleidomastoid muscle. So, anteriorly midline of the neck, superiorly superior belly of omohyoid muscle, and inferiorly sternomastoid muscle. Let's now dissect the contents of the muscular triangle, focusing on infrahyoid muscles, also known as strap muscles, due to their flat ribbon-like appearance. These muscles are key actors in the mechanics of swallowing and phonation. So there are two layers, superficial and deep layer. Superficial layer, the sternohyoid, omohyoid, and the deep layer, thyrohyoid and sternothyroid. So the superficial layer, sternohyoid, lies medially closest to the midline. It is a steadfast strap pulling the hyoid bone to the sternum. Then omohyoid position laterally with a superior belly forming part of the triangle's boundaries. So it's a strap connecting the shoulder blade to the hyoid, that means arm. The deep layer, thyrohyoid, sits above its neighboring sternothyroid, bridging the thyroid cartilage and hyoid bone. It elevates the larynx during swallowing. It elevates the larynx during swallowing. So then next we go to the sternothyroid, lies below the thyrohyoid, running from the sternum to the thyroid cartilage. So its action is it depresses the larynx after swallowing. Now let's shift our focus to the superficial layer of the infrahyoid muscles, which lies just beneath the investing layer of deep fascia, cervical fascia, and play a crucial role in stabilizing the hyoid bone during swallowing and speech. So first, the sternohyoid muscle, a long strap-like structure, extends vertically from the posterior surface of the manubrium sterni and insert into the body of the hyoid bone. Its primary action is straightforward yet essential: depression of the hyoid bone, especially after it has been elevated by suprahyoid muscles during the swallowing. Next, we encounter the omohyoid muscle, which is more complex in its architecture. It consists of two bellies, superior and inferior, so connected by an intermediate tendon. The superior belly insert into the hyoid bone, while the inferior belly originates from the upper border of the scapula. Coursing obliquely across the neck, the intermediate tendon lies deep to the sternocleidomastoid and is anchored to the clavicle by fascial sling, allowing the muscle to maintain its angulated path. Functionally, the omohyoid also contributes to hyoid depression, but its oblique orientation and facial connection suggest a secondary role in tension in the cervical fascia, which may assist in maintaining venous return through the internal jugular vein. Together, these muscles form a dynamic scaffold that supports the hyoid apparatus and modulate the position of the larynx during phonation and deglutition. Their superficial location also makes them key landmarks during anterior neck surgeries and tracheostomy procedures. So, having explored the superficial infrahyoid muscles, let's now descend into the deep layer where two shorter but functionally significant muscles reside, the thyroid and sternothyroid. Let's, let's begin with the thyroid muscle. It originates from the oblique line of the thyroid cartilage and ascends to insert on the hyoid bone. Unlike its superficial counterparts, the thyroid has a dual action. It depresses the hyoid bone and elevates the larynx. This elevation is particularly important during swallowing, helping to close the laryngeal inlet and protect the airway. So it's helping to close the laryngeal inlet and protect the airway. Functionally, it acts as a bridge between the infrahyoid and suprahyoid system, modulating both hyoid and laryngeal position with precision. Just inferior to it lies the sternothyroid muscle, which also originates from the posterior surface of the membrane sternum but insert directly onto the oblique line of the thyroid cartilage. Its primary action is depression of the larynx, contributing to the downward movements of the voice box after phonation or swallowing. This muscle plays a subtle but vital role in voice modulation and airway patency. Together, these deep muscles form a compact functional unit that fine-tunes the vertical positioning of the larynx and hyoid bone. Their actions are especially relevant in procedures involving airway management, vocal cord assessment, and thyroid surgery. Now turn our attention to the innervation of the infrahyoid muscle group, a detail that's often overlooked but critically important in both surgical and neurological context. Infrahyoid muscles are sternohyoid, omohyoid, and sternothyroid. So they receive their motor supply from the ansa cervicalis, a loop of nerves derived from the anterior rami of C1, C2, and C3. This loop lies embedded within the carotid sheath, and its branches descend to reach the target muscles, coordinating their actions during swallowing and phonation. However, there's one notable exception. the thyroid muscle, unlike its peers, it is not supplied by the ansa cervicalis. Instead, it receives direct innervation from the anterior ramus of C1, which travels briefly with the hypoglossal nerve before branching off to reach the thyroid. This distinction is clinically significant. Why? Injury to hypoglossal nerve or its C1 hitchhiker can selectively impair thyroid function, affecting laryngeal elevation and swallowing mechanics, while sparing the rest of the infrahyoid muscles. So it is important point. So when we are assessing neck trauma, post-operative deficit, or planning nerve blocks, always remember antecervical is for most but C1 for thyroid. Yeah. Now that we have outlined the flow of the muscular triangle formed by pretracheal fascia, let's take a moment to appreciate the layered complexity of the structures nestled within this group, uh, this region. Starting superiorly, we encounter the thyroid membrane, a key anatomical landmark bridging the hyoid bone and thyroid cartilage. Just beneath it lies the thyroid cartilage, recognizable by its prominent laryngeal prominence, or Adam's apple, a feature more pronounced in males. Descending further, we, we meet the cricothyroid ligament and muscle, which plays a vital role in tension in the vocal cords. This is clinically significant, especially in emergency airway access via cricothyrotomy. Below that, the cricoid cartilage marks the only complete ring of cartilage in the airway, an important anchor point for both anatomical orientation and surgical procedures. So, continuing inferiorly, the tracheal ligament connects the cricoid cartilage to the trachea, which itself begins just below this junction. The trachea, as we know, is the conduit for air passage to the lungs, and its anterior surface is often obscured by several vascular and glandular structures. Among these, we find the jugular arch formed by the union of the anterior jugular veins, a subtle but relevant landmark during neck dissection. The inferior thyroid vein also crosses here, draining into the brachiocephalic vein, and finally, the isthmus of thyroid gland spans across the second and third tracheal rings, anchoring the two lobes of the gland.